Here we have a classical ulnar flow, and this is suggestive of ulnar nerve palsy. So to understand why this happens, where you see there's hyperextension in the metacarpophalangeal joint and hyperflexion in the interphalangeal joints, we must understand what are the muscles that the ulnar nerve supplies. So starting from the common flex origin, ulnar nerve supplies the flexor carpi ulnaris and medial half of the flexor digitorum profundus. And in the hand, it supplies the hypothenar muscles, which are on the medial side, you find the abductor digiti minimi. On the lateral side, you find the flexor digiti minimi. And underneath, you find the opponent's digiti minimi. And it supplies the medial two lumbricals, which supplies these two fingers, and also the dorsal and palmar interossei muscles. So, and also on the lateral side, it supplies the adductor pollicis. Okay, so the patient has ulnar nerve cut from near the wrist. So because of that, all the hand muscles that the ulnar nerve supplies beyond this point are not supplied, whereas the muscles supplied before the cut are still supplied. So that's an important point to remember first. Now, when we discuss about the ulnar claw, we see two components. That is, one is hyperextension of the metacarpophalangeal joint and hyperflexion of the interphalangeal joint. The hyperflexion component of the ulnar claw arises because the extension action of the lumbricus is lost, but the action of flexor digitorum profundus is still there. Therefore, hyperflexion of the finger occurs at the interphalangeal joint. The hyperextension of the metacarpophalangeal joint occurs because flexion of the metacarpophalangeal joint of the lumbricus is lost, but the extensor digitorum still acts and it extends the finger at metacarpophalangeal joint. So usually in other nerve injuries, when the nerve injury occurs more proximally, the signs are usually great. But in ulnar nerve, we have something called ulnar nerve paradox, where the more the injury occurs more distally, the greater the signs are. So, and this occurs because when the nerve injury occurs more distally, it had already supplied the flexor digitorum profundus, and then the action of lumbricus is lost. Therefore, hyperflexion occurs. But as the injury occurs more and more proximally, the less nerve supply goes to flexor digitorum profundus, and therefore less flexion occurs. And when it goes above the flex origin, then both the flexor digitorum profundus and the lumbricus are not supported. Therefore, you find usually the fingers to be straight, even though ulnar nerve injury occurs. In a patient where the ulnar nerve injury had occurred above the flex origin, the ulnar flow is less visible, right? And that's because the flexor digitorum profundus and lumbricus both are not innervated. Therefore, the ulnar flow doesn't appear as strongly. But then after treatment, when the ulnar nerve is growing again, ulnar claw begins to appear. And that is because the flexor digitorum profundus is re-innervated by the ulnar nerve. And as it grows more and more distally, ulnar claw exaggerates. And also, as the ulnar nerve grows, following the nerve, you can tap on it. You can tap on the arm, and where the ulnar nerve is growing, the patient feels a tingling sign, and as it grows, that tingling sensation is felt more and more distally, and we call that advancing tinnitus sign, and that is a positive sign that the nerve is growing. So another confirmatory test for ulnar nerve injury is to see if the adductor pollicis muscle is working. So adductor pollicis allows adduction of the thumb, supplied by the deep branch of the ulnar nerve. And to see if adductor pollicis of the patient is working, we ask the patient to hold a paper between his thumb, and we are going to pull it away and ask him to keep the paper with him. So when we do that, you see because his adductor pollicis is not working, he's flexing his thumb but using flexor pollicis muscles. So we call this sign as Fromen's sign, and this is suggesting of an ulnar nerve injury. Okay. In clinical presentations of ulnar nerve injury, sometimes there could be exceptions. And one of those common exceptions is due to mountain goop anastomosis. And that's about 20 to 30% of the population. So it could be relatively common. And the reason what mountain goop anastomosis is basically a branch from median nerve, anastomosis of the ulnar nerve. Therefore, even though the ulnar nerve is damaged, you could still see some motor functions of muscles that ulnar nerve usually supplies. And then you have something called congenital flexing deformity, where the little finger and the ring finger is partially flexed. So this sort of looks like an ulnar claw. And even after, so in a case where such a patient gets ulnar nerve injury and gets ulnar claw, and then after treatment the ulnar nerve is fully grown, the patient still may have something that looks like ulnar claw. But then this is actually pretty normal. In that case, you should ask the patient whether he had such a deformity before. Maybe you can compare both hands, but sometimes it comes only in one hand. So that's not the case. And also in ulnar nerve injury, one of the branches also supplies a head of flexor pollicis brevis. So in that case, it's a deep head, not the superficial head. So usually the thumb flexion works fine, but there will be a certain weak.